Good morning, everybody. And I'm so glad to be here on the Indian Radiologist platform today, all thanks to Dr. Malini. So, as you can see, multiple causes of shoulder pain, and many of these can be attributed to the rotator cuff as well. So, my learning objectives for today's session will include the following. We'll be talking about the anatomy and function of the rotator cuff, some of the technical aspects related to MR imaging of the cuff, the pathophysiology of cuff injury, and especially in detail, I'll be focusing on what to report in the MRI so that your report is clinically relevant and not just consisting of, lots of text, but not that information which a surgeon is looking for. So let's start with the anatomy. And Dr. Malini also had covered this part quite well, but I'll just do a quick review of this. See, the shoulder joint is basically consisting of the articulation between the larger humeral head and the glenoid, which is shallower. So there is always a balance which needs to be maintained between the stability which is required for the shoulder joint as well as the range of mobility which we expect in different movements from the shoulder joint. Now, there are two types of stability which are important to us, two types which are maintained by different structures. Some structures give static stability to the joint, and they include the osseous structures, the joint capsule, and the labroligamentous complex. And then there is the rotator cuff, which is giving dynamic stability to the shoulder joint. So we have four rotator cuff muscles, as you already know. They are supraspinatus, infraspinatus, teres minor, and the subscapularis. So if you see from the dorsal aspect of scapula, from the supraspinous fossa, we have the supraspinatus, which is inserting onto the superior facet of the greater tuberosity. Then we have the infraspinatus, which is larger and inserting onto the middle facet of the greater tuberosity. And then we have the teres minor, arising from the dorsolateral border of the scapula and inserting onto the inferior facet of the greater tuberosity. From the ventral aspect, we have the subscapularis, which is a large multipennate sort of muscle, and this will attach to the lesser tuberosity. Now, fibers of this will also help in the formation of this transverse humeral ligament, which will stabilize the biceps tendon in the bicipital groove. But remember that these muscles of the rotator cuff, they are just not working in isolation, that one muscle doing one function. They are like part of a functional and anatomic unit. So if one muscle or one tendon gets torn, that's going to affect the function of the other as well. So like for example, we have the supraspinatus inserting onto the superior facet of the greater tuberosity. But some part of the supraspinatus also inserts onto the middle facet. And when this is the infraspinatus inserting on the middle facet, there is this area where there is interdigitation of fibers of the supraspinatus and the infraspinatus, which people also call as the conjoint tendon. So there is interdigitation not just between supra and infraspinatus, but also some interdigitation of fibers occurs between subscapularis and supraspinatus and even the infraspinatus and the teres minor. So what you need to remember is that suppose you've been able to identify a tear in one tendon, don't just stop there. You need to look at the entire cuff because the function of one is also affected by the integrity of the other. Now, one more thing before I finish the anatomy part. There is a concept of a rotator cable and crescent. So this thick band of fibers, which is indicated in yellow over here, is known as the rotator cable. And this band of fibers is passing beneath the supra and the infraspinatus. Okay. And this is supposed to kind of stress shield the lateral part of the cuff, which is known as the crescent. So we have the cable, and the distal fibers of the rotator cuff beyond this are the crescent. So this was earlier supposed to kind of stress shield the crescent. Okay. So it was thought that, okay, if you have a tear in the involving the cable and the crescent, If you just direct your energies to this cable part and repair the cable, then the crescent would not be so much affected, it would be just fine. But now newer concepts and newer researches which have been published now in the Journal of JBJS, Bone and Joint Surgery, say that the cable is not actually stress shielding the crescent, but the crescent it's itself involved in force transmission during shoulder abduction. So if you don't repair the crescent, that's going to be really bad and will not serve the purpose of surgery. So you need to address both the cable as well as the crescent. A couple of other things. This is the coracoid process, the coracoacromial ligament and the acromion. And beneath this is passing the supraspinatus. So this entire thing is called as the coracoacromial arch. So if there is any problem related to the coracoacromial arch, like a thickened hypertrophied ligament or some enthesophytes from the acromion or acromioclavicular arthropathy, then it's going to cause impingement on the rotator cuff and may lead to tear. Another important structure is this, indicated in blue, that is the subacromial subdeltoid bursa. So this is beneath the deltoid and the acromion and above the supraspinatus. So it allows for a smooth, frictionless movement of the supraspinatus. Now with that I've finished up the anatomical part. So let's go on to some of the technical aspects related to MR imaging of the cuff. So you can use a magnet strength of 1.5 Tesla or 3 Tesla, depending on what is the availability in your center. These set of sequences which I have mentioned here are those recommended by the ESSR Sports Subcommittee. Now, according to them, we can use PD fat saturated sequence in all the 3 planes, and we can use 1 T2 and T1 in coronal oblique T2 and sagittal oblique T1. However, I must tell you that now people are moving towards using only PT and PT fat sat in all the 3 planes. And latest concepts are now saying that you use Dixon in both the in all the planes, and that will give you much faster and better quality imaging of the cuff. But to conclude this, I would like to say that you must find your set of sequences which you are most comfortable with and you think kind of balances the time and the image quality. Now, only for the residents, I've just put limited images of the normal rotator cuff so that we can then you can have an idea of what normal looks like, and then in the subsequent images, you'll be able to appreciate the pathology better. So this is a coronal section. Here, this is the supraspinatus muscle, and this is the supraspinatus tendon, which is attaching onto the greater tuberosity of the humeral head. This is the glenoid with the anterior and the inferior labrum. So you can see that it looks dark and homogeneous and very uniform in caliber. So this is how a normal tendon looks like. This is the sagittal oblique section and this is the humeral head. And we can see the attachment of the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. This is an axial section in which you can see the supraspinatus muscle, but you don't see the tendon so well. These are further axial sections. Here you can see the infraspinatus tendon. This is the infraspinatus tendon. This is the bicipital groove. In this section, you can see this is the glenoid, the anterior labrum, the posterior labrum, and this here is the tendon of the subscapularis, which is attaching onto the lesser tuberosity. And here, this is the biceps tendon in the bicipital groove. And lastly, here you can see the teres minor tendon. Now let's come to the pathophysiology of cuff injury. So basically, there are 2 concepts, that it can be intrinsic or it can be extrinsic. By intrinsic, we mean that the tendon is degenerated, and that degeneration can be linked to certain risk factors also, like a person who's been smoking for a long period of time, high cholesterol levels, and some genetic predisposition. And then there are some extrinsic factors, like something like a hooked acromion or AC joint arthropathy, which is constantly impinging upon the cuff and then leading ultimately to a tear. And then, of course, there is trauma. So trauma is another thing which can cause an acute cuff tear. What is the spectrum of pathology that I'll be basically covering in this talk? So we'll be talking about tendinosis and tears and the entire spectrum of tears, which will be a revision of what Dr. Ashwin has already told you. So what exactly is tendinosis? See, this to your left is the image of a healthy tendon. So what does a healthy tendon have? It has a very good, smooth, nicely packed arrangement of collagen fibers. And there is no abnormality in the adjacent soft tissue or the extracellular components. But when we think of tendinopathy or tendinosis, as you can say, what happens is that there is a disorganized or a haphazard arrangement of the collagen fibers, and even the fibroblasts, they have an uneven distribution throughout the tissue. There is some neovascularity with increased ground substance. So remember that we do not use the term tendinitis for this because this is all non-inflammatory degeneration. So we call it tendinosis or tendinopathy. Next, coming to tears. So, there are different types of tears. They can be partial thickness tears and they can be full thickness tears. So when we talk of partial thickness tears, there can be these types. See, some of the tears can be facing the joint part and some of these can be facing the subscapularis subdeltoid bursa. So those partial tears, meaning which are involving only some of the fibers of the tendon, if they are facing the articular part, they are called articular-sided partial tears. If they are facing the bursa, they are called bursal-sided partial tears. And if they are within the substance of the tendon and not involving either the articular side or the bursal side, then they are known as intrasubstance or interstitial tears. Then you have full thickness tears. So full thickness tears can extend completely from the articular side to the bursal side. So for full thickness tears, you can have either partial width or you can have complete width. So if this is the thickness of the tendon and only the central part, let's say, has a full thickness tear, so it will be an incomplete full thickness tear. But if it is involving the entire thickness of the tendon, the full thickness tear, so that will be a complete full thickness tear. Now, for those of you who have been sleeping soundly, it's time to get up because now we are going to begin with the most important part of the presentation. Okay, and this is what to include in the MR report. So we will be covering all these things ranging from your identification of tendinosis or tear, further characterization of the tear, including its type, its location, size and shape, its extension, the degree of tendon retraction, changes in the muscle, which include atrophy and fatty degeneration, and any associated abnormalities or causes, which indicate the cause of the tear. Now, if you see the image on the left, you'll see nice, good-looking tendon, homogeneously dark. When you see this, here the tendon looks mildly thickened, but there is nothing to show a fluid signal in the tendon, which would have indicated a tear. So it is just mildly thickened and non-homogeneous. So this is a tendinosis. Now compare with this. Here what do you find? That at the footprint, you are seeing a partial thickness tear. So there is fluid signal intensity over here. And this is not involving the entire tendon thickness. So this is a partial articular-sided tear. Compare with this. Here the bursal fibers are involved. And this is a partial bursal-sided tear. So partial thickness tears at the footprint are also known as rim-rim tears. But believe me, I don't believe in labeling tears as something. What I believe best is that you need to identify and describe the tear as best as possible. Now, this is the subscapularis. So here you can see subscapularis is a large muscle, so superior and inferior fibers, and you can see joint effusion and a partial tear in the subscapularis tendon. Now, this is a larger partial thickness tear. Only some fibers are seen attached, but the depth of the tear is more. This you can compare with corresponding T2 image also, right? So, some are smaller tears and other are larger. I will be talking about the size where I'll tell you the exact dimensions we use. Come to this tear now. So here nearly all the fibers nearly all the fibers of the tendon are torn, extending from the articular surface to the bursal surface, and there is a small fluid collection in the subacromial subdeltoid bursa. So those were partial thickness tears, and this is a full thickness tear. Now, how to measure and what to write, when to write small and when to write large or massive. For full thickness tear, we use the grading of less than 1, 1 to 3, 3 to 5 centimeters, and a massive tear is anything which is larger than 5 centimeters. When it comes to partial thickness tear, we use depth. So less than 3, 3 to 6, and more than 6, because average tendon thickness, let's say, is about 12 millimeters or ranges between 10 to 12 mm. You can also just write low grade and high grade. So if it's less than 50% of the fibers is low grade. If it's more than 50% of the fibers or grade 3, it is high grade. Now, for example, look at this. This is a full thickness tear, but it looks small because you can see only this much is the greatest dimension. On the other hand, towards your right is an image where you see there's a larger full thickness tear. So that's how you need, it's important to describe, the size, so that the surgeon actually knows what is the maximum dimension of the tear. Their plan of surgery can change depending upon what size of tear you have mentioned in your report. Then considering shape. So there are some tears which are presentic. There are tears which are larger U-shaped tears, and there are some L-shaped tears. Now, this L-shaped and U-shaped don't look good to the surgeon because primary repair, if it's done, will put these areas under tension. But if it's a small presentic tears, it looks like it will have a favorable outcome even with primary repair. Next, we come to tumor extension. Tumor extension means that we have to talk about what additional structures are involved, whether the tear is just involving the supraspinatus or anteriorly it has gone up to involve the rotator interval structures, and posteriorly it is involving the infraspinatus. So then again, the surgeon has to plan accordingly. For example, here, this is a massive full thickness tear, right? And it is also involving the infraspinatus. So again, the surgeon will need to plan accordingly. So remember, extension of the tear is important to mention. Then tendon retraction. Suppose it's a small tear, tendon fibers are just adjacent. Larger tear, they may go up to as much as the midhumeral head. And massive tears, the tendon may be retracted even up to the level of the glenoid. And this, this may put the surgeon in great difficulty if it's such a massive tear with significant tendon retraction. Let's see these cases. So this is a full thickness tear, but tendon retraction is only close by. Here, the tendon has gone up to the humeral head. And now here it is almost going up to the glenoid. So that becomes important for you to mention so that surgeon can plan accordingly. And then muscle atrophy. Suppose the surgeon has, is thinking of doing a repair and you're saying all the muscles are normal. So he'll think accordingly. But the problem will be that if the muscles are not fine, then the tear, just repair of the rotator cuff will not bring the expected outcome. And they will put the surgeon also in a difficult position if he has prognosticated the patient. So remember to talk about muscle atrophy. I feel happy working with the tangent sign where you draw a line from the scapular spine to coracoid and from here to the tip of scapula. If your muscle is going above these lines, it's normal. If it's even with these lines, then mild atrophy. If it's less than these lines, but about 50% of the height of the fossa, it's moderate atrophy. And if it's below that level, then it is severe atrophy. Similarly, we have to talk about fatty degeneration also. Here we have a Guttalier staging on CT and a Fuchs stage on MRI. And for MR, if it's normal muscle or just some fatty streaks, we just say it's grade 1 and normal. We just say it's grade 1. If fat is less than muscle, it's 2. If fat is equal to muscle or more than muscle, that we put it as stage 3. Now, this is normal, good-looking muscle, good bulk, and not much of fat that you see. And here, for example, I've put 2 patients with full thickness tears. But see how the plan of surgery may be altered. This muscle shows normal bulk and some fatty streaks, right? But here, look at the supra and the infraspinatus. There is significant atrophy of the supraspinatus, and also you can see almost uh, stage 3 changes in the degree of fatty degeneration. So again, that becomes important for the surgeon. Lastly, we talk also of any associated abnormalities or causes that we can pinpoint as to be the cause of the tear in some patients. For example, these are different types of the shapes of the acromion. And this type 3 is the one which has a hooked acromion. So this can, damage the rotator cuff. So in this image, you see a hooked acromion. Here you can see an os acromial, and here you see AC joint arthropathy, acromioclavicular arthropathy. So all these, they can contribute to rotator cuff impingement and subsequent tearing. So I think I'm just in good time. Yeah. So let's look at this chart. And what does this say? These are the factors which don't look good to the surgeon. So if it's a massive tear with a U-shape or an L-shaped configuration, the tear is extending to involve the rotator interval, the subscapularis, or the infraspinatus. There is increased degree of tendon retraction. There is muscle atrophy and fatty degeneration. So all these things do not look good to the surgeon. See, the surgeon has to keep in mind also what's the age and what is the expected functional outcome before he's planning the surgery. So there is a difference. If it's a young patient who is let's say, an athlete and wants to go back to surgery after a cuff repair, that's a different type of patient. If it's an elderly 75-year-old lady who is, who just wants some basic restoration of function, then the expected functional outcome is totally different. So you have to think like that. You have to think like what the surgeon actually, wants the information, wants the information from your report. And this is what, again, I would like to emphasize. You want to tell about whether it's just tendinosis or a tear. You want to talk about the location, size, and the shape of the tear, the extension of the tear, the degree of tendon retraction, the changes in the muscles, and any other associated abnormalities or causes you can pick up which can lead to rotator cuff damage, right? So I think I've said enough now, and I hope you're wiser by the end of this presentation. And always remember, the step towards improvement is one small step at a time. So thank you all for your kind attention.
Thank you so much, ma'am, for the wonderful lecture.
Thank you.
Ma'am, we have a few couple of questions in the chat box.
Okay, is there time for me to take them, or I can take them later?
Ma'am, either you can take them now or you can answer them in the chat box.
Okay.
So I think you can answer them because we have a couple of them. There are 4 to 5 questions.
Okay,
So,
okay.
yeah, we can type the answer.
So someone is saying how to see a U-shaped or an L-shaped tear. So this, for this, you have to see the shape of the tear in all the planes, right? So once you're assessing the tear morphology, I would always say that you need to see in all the planes. Like you cannot make out an axial, but if you see coronal or sagittal and also go back to your axials, then putting it all together, you'll be able to identify the configuration. Fluid signal to be confirmed on T2 or PD. See, fluid will be bright on T2, of course, and it will also look a little brighter on PD. But what I do is that I take in coronal oblique both the PD fat sat and T2, and the tear shows hyper intense signal corresponding to fluid on T2s. How to describe an acute tendon injury without tear? Can we call it acute tendinosis or sprain? So no, I don't use the term acute tendinosis. Actually, tendinosis is actually due to a chronic overuse sort of thing, in which you can see either a normal or a slightly thickened tendon with non-homogeneous signal intensity. So I don't use these words acute tendinosis or sprain. when it's tendinosis, that is what I just described, I refer to as tendinosis. And when it's a tear, then I call it a tear and I describe it in the way that I just told you, whether it is partial thickness tear and mention the depth of the tear, and whether it's a full thickness tear, it is complete or incomplete. I don't use these terms. Adhesive capsulitis, what should we mention in the report? Actually, I was not talking about adhesive capsulitis. There are multiple findings in adhesive capsulitis. But there are multiple findings in adhesive capsulitis, and I can talk about them at length. But I think that I was not talking about this in this particular session. However, if you want to know, so then there can be effacement of fat in the rotator interval. There can be thickening of the coracohumeral ligament. There can be thickening of the inferior glenohumeral ligament, part of the joint capsule. And there can be also edema in the subcoracoid fat. So, see, for ultrasound and MR, let me tell you that if you just want to focus on the rotator cuff, MR, ultrasound is really good in good hands like those of Dr. Ashwin. But if you want to, besides the rotator cuff, you want to talk about the labrum and the osseous structures as well as the joint capsule, then MR is the way to go. And adhesive capsulitis, I mentioned the findings, you can write them in detail.